Well, thanks, Gary. I feel like I'm sort of one of the few outsiders, but perhaps the only outsider insider here, having spent most of my career at the University of Washington. Um, and I have to say, when Gary and I were attending a Robert Wood Johnson Foundation meeting in Orlando, Florida, many years ago, we had a grant to do some follow-up work on the managed care pilot. And it was late in the afternoon, and both of us had a long flight back to Seattle. And we started talking about, well, what would be the next possible building block on the managed care pilot, because Washington is a worker choice state, and you can't direct workers to any particular network of physicians. And we sketched some ideas out and some principles on the back of a napkin, which unfortunately I didn't save, so now it'll just be part of the folklore of the COHE. But these principles actually over time, as Gary said, with great collaboration between folks at the UW and L&I, and what emerged from that is what I'm going to talk about here for the next several minutes. I would just like to point out that we had a great team. A number of these people are in the audience. Bob Moots, where's Bob? He's back there. Who has a great asset? Terry Smith-Weller. Terry, where are you? Don't be shy. There's Terry Smith-Weller, Diana Driley, Susan Campbell. So it was, and others who are not here. But it was a great team. I was fortunate enough to serve as the lead evaluator, but by no means do I take credit for what we accomplished. In listening to the first part of the presentation, most of you are here working in one way or another in the trenches, but I don't think you fully appreciate maybe you do, what you've accomplished here in Washington. It really is just terrific work. As somebody now who was in Washington formerly, is now in Ohio, most of you know, sadly, Ohio is the epicenter of the opioid epidemic. Even though we don't have the largest population, we lead the nation in opioid overdose deaths, and those deaths are continuing to increase. And I can tell you I should be a little careful because I'm on tape here. But I would say there's some very dedicated, committed, smart people in Ohio, both at Ohio State University and state government. But Ohio is probably at least a decade, if not 2 decades, behind what is all going on out here. So I think those of us in other states can learn a whole lot from the great work that's going on here. So let me get started. Leah, should what's on there be on this screen? It's not. I probably didn't push a button that I should have pushed. That's not on the screen. Oh, all right. Okay. That's all right. Okay, we're off to a good start here. So just, yeah, I'm not going to read it. Several objectives here. What I want to talk a little bit about, I'm going to give you the history of the COE, but really to have you think about it as a large system transformation. What I'm going to be talking about and reviewing is the development of this COE as an example of a large system transformation. Going to briefly review some of the design features of the COE, review some of the outcomes, and then talk a little bit about the COE as a system platform for collaborative care and step care management. So many of you may know Washington State is the way that the workers' comp system is set up here. It's organized as a state fund. It's administered by the Department of Labor and Industries, so all employees who work for firms that don't self-insure must by law be covered by workers' comp insurance purchased through the Department of Labor and Industries. And what that means, among other things, is that Labor and Industries is a single payer system for workers' comp and healthcare. And at least my experience over the years working with, Gary and others doing this work is that no matter what you think about the virtues or the disadvantages of a single payer system to finance care, there are huge advantages from the point of view of having an entity that's able to do, at least make some progress in population health and to actually take responsibility for initiating innovative pilot work, which is what's been done. So LNI insures about 2/3 of the non-federal workforce in Washington. So what is a large system transformation? Best and colleagues in an article in Milbank Quarterly defined it this way: large system transformations in care are interventions aimed at coordinated system-wide change affecting multiple organizations and care providers with the goal of significant improvements in the efficiency of healthcare delivery, the quality of patient care, and population level outcomes. So I think, as Gary mentioned, the COHE pilot built on an earlier managed care pilot. The aim of that pilot was to determine whether organizing care delivery through managed care could reduce disability, improve health and cost outcomes, and increase worker and employer satisfaction. But it was very different from a lot of the managed care work that was going on in the late 80s and in the 90s, in the sense that it wasn't fundamentally a cost containment activity. It was really an activity designed to see if reorganizing care under managed care arrangements could achieve these outcomes. So this is a slide showing the basic overall results. I revised this slide. This slide used to be, I used to use purple and gold when I was at the University of Washington, the Husky colors, but now it's scarlet and gray for Ohio State. So you would pardon me. After I move back here, I'll change the colors of the slides. So we found what we thought we would find and what the literature suggested in terms of medical costs. Medical costs were paid on a capitated risk-based basis. I won't go into those details. And so we found in the managed care arm, which is in the the scarlet or orange bar, reduced costs. But the disability payments were handled in the normal way from LNI. There was no change in that. The managed care clinics were not at risk at all for those payments, and yet we found a very substantial decrease. And while it wasn't a randomized trial, so some of that decrease could have arisen from self-selection, but certainly not nearly all of this. And part of it, we came to feel, we did some qualitative work and other work, was the way that care, this managed care, was organized at the clinic level. The clinics had to have case managers. The medical directors of the clinics had to be board certified in occupational medicine. There was a concerted effort to improve communication with employers, had to use evidence-based medicine to the extent that they could, et cetera, et cetera. So we came to call that the occupational medicine model. And the question became, this study came to an end, what could L&I do next to build upon this experience and what we learned from this pilot? And that really became the foundation for this large ongoing pilot and now revised system that I'm going to talk about. So I like to think of disability prevention as, in a way, a kind of good news, bad news story. And the bad news is that workers who remain on disability longer than about 2 or 3 months have a greatly reduced chance of returning to work. But the good news is that health outcomes can be improved and long-term disability reduced by effective care coordination, by increasing organizational support, strong administrative and clinical leadership, and aligning financial and non-financial incentives. These were some of the things we did in the COHE and that were also done in the earlier managed care pilot. So I think the challenge in terms of certainly system levels of care is how do you move that blue line is actual data from LNI, Washington State Injured Workers. And what it shows is that most injured workers go back to work fairly soon after their injury. But you'll notice there's an inflection point at about 3 months, and then that curve very much flattens out. When these data were polled, and I think it was probably around 2000, I'm not completely sure, could have been a little earlier, you had about 18%, give or take, of the people on average on disability and out of work at 12 months. And the challenge was to move that line, that curved line, closer to the origin, so that instead of 18% of the injured workers being out of work at 12 months, you might reduce that to 10% or even lower to 5%. And so that in that window of time, 1, 2, maybe up to 3 months, is really the period of early intervention that we focused on in the COHE, and that I think provides the opportunistic, if you will, window for step care management and where collaborative care becomes really important. Certainly it's not important when you get out to the tail of that distribution. Then it's too late. So how did we redesign care through these COHEs? Well, we had a series of meetings in Seattle back, I want to say, about 1998, where we brought national and regional experts to Seattle along with local folks to talk about what is important in terms of improving quality for 3 conditions: carpal tunnel syndrome, back sprain, and extremity fractures. And out of that came 4 indicators I'll mention in a minute that became some of the glue of this pilot work. And so we developed community-based COHEs. Originally there were 2 COHEs, one in Renton, one in Spokane. This was the original pilot that got off the ground at about 2001. And some of the quality improvement activities are listed here. Care coordination through health services coordinators were hired. Mentoring and CME were provided for the community physicians. Treatment guidelines were disseminated along with best practice information. And there was a real focus on medical leadership. So these were some of the specific intervention components. They're grouped into 2 groups. The first we called structural change components. I'm not sure that's the best label, but one was physician continuing medical education. Then 2 was health services coordination. That was an attempt to improve care coordination, improve communication, and reduce provider administrative burden. I don't think I've met a physician when you mention workers' comp that they start smiling. Usually they will turn and head for the closest exit. But we really tried to the extent possible to change and improve their 8 to 5 clinic work life. Because I think if you can't do that somehow, you're not likely to achieve success. And then we tried to improve patient tracking. I think that was mentioned earlier. That's obviously critical. And then the other component was the financial incentive component, enhancing provider payment. We paid for best practices, and they're listed here: submission of the accident report. That's the initial report that has to be submitted and approved in order for the claim to be approved and care to be paid. Use of activity prescription form. We came up with a new form that replaced, I think, 3 other forms, so the physicians were thrilled about that. Communication with the employer, and then return to work impediments assessment. And importantly, we incentivized, let me see if this is on the next slide. No, it's not, so I'll talk about this right now. So we incentivized physicians to adopt these best practices by paying. LNI developed new billable codes for some of these. And so every time they did one of these best practices, they either got paid, or if they were paid earlier, for example, for the submission of the accident report, they got paid more if they got that in within 2 days. So I don't know how many of you are familiar with the literature on pay for performance, but that literature really hasn't shown that matters too much. And I think one of the fundamental problems is paying physicians at the end of the year or the end of the quarter for achieving some benchmark or achieving some metric representing improvement is, with all due respect to people that were in the early work in this area, were smart enough people, but I don't know if they ever took Psychology 101 in college, because the reward is not linked to the behavior that you want to change at all. Whereas in the COE, it really was. They got actually paid more. Their clinic got paid more every time they did one of these best practices. So this is just a schematic to show you that COEs really became responsible in the community level. So first in Renton, then in Spokane, for recruiting physicians. So this wasn't a bricks and mortar thing. The COEs, they marketed the pilot, they went out, they signed up physicians. There were agreements with L&I that were created. A group of us at the UW performed the evaluation. Importantly, we had a business and labor advisory group that turned out to be really critical to the success of this. I'll talk more about that a little bit later. And I think this footnote at the bottom, if you can read it, is important. I sort of view the COHE as an example of, everybody's probably familiar with Don Berwick and the Triple Aim. He had a health affairs paper in 2008, and he talked about the importance of an integrator. You really, if you were going to achieve the Triple Aim, you had to have an integrator, some entity, some organizational entity that would take responsibility for care, that would take responsibility for care coordination, and so on and so forth. And the COEs, I think, in some way really became an example of an entity that fulfilled much of that function. And so we did, as I mentioned, an initial pilot evaluation. I'll show you the results of that in just a minute. There were two key sub-analyses we performed. One was to look at back sprain cases, because the COE was really designed to improve care coordination. And if you think about it, patients with a simple laceration or a contusion, they don't really need much care coordination. They're going to go to an urgent care center and get, half a dozen stitches and then, be back at work the next day. But that, of course, that's not true with back sprain for the most part. And we also then wanted to take a look and compare physicians who adopted these best practices more often compared to those that adopted them less often. Because on the simple sort of premise that if these best practices are really as important as we thought they were, physicians who adopted them, COE physicians, not the control community physicians, COE physicians that adopted them more often as opposed to less often should have better outcomes. So we had fairly large numbers. These are the numbers for the original pilot evaluation in Renton and in Spokane. And this is the data. It's a good thing that I had my cataract surgery here a couple years ago. I never would be able to read that screen. So what's in parentheses are the back sprain cases. And you can see, I'm not going to go through the whole slide, but you can see there was some self-selection. The COHE patients at baseline were less likely to be on disability a year. They had fewer disability days in the baseline period, fewer disability costs, and fewer, lower medical costs. But if you look at the numbers in parentheses comparing the COE group in the baseline year with the comparison group in the baseline year, you see they're almost identical. And I have no explanation for that whatsoever. It was about 15,800 back sprain patients, but they're almost identical, which was reassuring to us in terms of the analysis. So what did we find? So this slide summarizes the major findings, that we have all cases in the left-hand column, the back sprain cases in the middle column, and the high adopter versus low adopter analysis I just mentioned in the right-hand column. And so you can see in terms of being on disability and out of work at 1 year, there were significant reductions in the risk of that, particularly among the back sprain cases and the high adopter group of patients treated by those physicians. In terms of disability days, on average, there was about a 3.3-day reduction in the pilot cases compared to the controls. 8 days for back sprain cases and basically 7 days for the high adopters compared to the low adopter physicians. And you can see correspondingly disability costs were also less. Medical costs were less, but those differences were not significant. However, the medical costs includes the additional payment we made to physicians. So had we not included them, and frankly, I don't know why we did, that was probably a poor decision on my part. The medical costs, there would have been a greater reduction in the medical costs. It probably would have been statistically significant. But obviously, very meaningful findings. These are one-year follow-up. So this is based on all the cases that were treated by the COE physicians, and the control physicians, I should have mentioned this, were all the physicians in the catchment area in Renton and Spokane that did not sign up for the COE. So it is important to understand physicians that signed up on the COE did so on a self-selection basis. So from an evaluative point of view, obviously you're concerned about that, but we couldn't do this kind of study in randomizing patients. So more recently, we've taken a look and turned attention to long-term effects. And in particular, as many of you might know, the federal government, the Social Security Administration, has had for a number of years, has sought to address the problem of the growing costs and growing roles of people on Social Security disability insurance. And in fact, last year in 2016, that insurance fund went broke. Congress threw it a 10-year lifeline. But they're continue to be concerned about not only really the cost, but once you get on SSDI, you're by definition out of the labor force. And probably many of you have read or seen on the news a major social problem in this country has been the proportion of working age males that are not in the labor force. It's at an all-time historic low. And part of that, certainly not all of that, but part of that is just what Gary and others have mentioned, that people get a routine back sprain or shoulder sprain or knee sprain. They don't get the treatment that they should for that. They may suffer from some depression. They may get on opioids. And 5 years later, they're exited from the labor force and they're on SSDI. And that's not only costly, but I think more important, it represents a personal and a family tragedy for those people. So we've gotten 8-year follow-up data on the original cohort of 105,000 patients. I'm doing some analysis as of right now. And some of the preliminary results are, compare the COHE to the controls controlling for, I didn't bother to talk about all this, our statistical analysis, but we can control for a number of things. You observe a 26% reduction in the risk of exiting from the labor force and going on SSDI over this 8-year period. The unadjusted differences in mean disability days and days per 10,000 injured workers are shown here at the bottom of the slide. It's about 35. This is all cases. The 26% reduction are just back sprain and other sprains, because those are the cases that are most likely to end up on SSDI. It's about 35 days versus 58 days, but when you transform that on a more of a population basis on a rate per 10,000, you see that the difference, this is unadjusted, so got to keep that in mind. The difference in the COHE and the controls amount to, over this 8-year period, amounts to 634 years of productive work time lost. That's per 10,000 workers. That is enormous. And so we tend to forget when we view these studies and their point estimates of risk reduction or costs, that when you roll those numbers up on more of a population basis, there is and you look over time, not just a year out, but in this case 8 years out, there are really some very, very substantial differences on a population basis, again, in disability suffered by these workers. So the current state of COHE, I don't know if Gary mentioned this, but in March 2011, the legislature passed a law expanding the COHEs on a permanent statewide basis. There are now 6 COHE sites with well over, I think, 2,500 physicians providing occupational health care to roughly 60% of the injured workers. And care coordination has become a billable service, so that's going to provide us, I think, with an opportunity to take a deep dive and look more closely at the effects of care coordination. Risk assessment is performed to identify high-risk cases. And so I think of the COE as really providing a system platform for the delivery of step care management, which is now what I want to turn to. Leah, how am I doing for time? Okay. Yeah, I just didn't want the 1 minute to pop up here. So the COE sites provide, I think, desirable clinical settings to incorporate some of what we've been talking about earlier: step care management, collaborative care within the delivery of routine occupational health care. I think it's fair to say this is somewhat of an early work in progress in terms of putting in the tools and the systems and the procedures and the policies that need to be put in place. But the COE sites are now, and they will be implementing new processes and tools to support step care management and collaborative care to address the opioid problem. So, I'm not going to repeat this. I think it's already been talked about. A lot of this came out of the work of Ed Wagner and Michael Von Korf and others at Group Health, now Kaiser. It really was originally focused on integrated care in the mental health arena, but now it's really been adopted for, it's been mentioned, for pain management. And it seems to me that step care management, among other things, but requires care that's both proactive and accountable. And so what are the principles of collaborative care? I don't know that I'm going to read them here. I think we've seen them already, but these are what's, I think, generally recognized as some of the important principles of doing this kind of care. The COHEs are beginning to provide screening for high-risk patients. They're implementing procedures to screen patients at risk for extended disability. That has come out of earlier work that Gary and Judy Turner and others have done at the UW and at LNI. I'll talk about that in just a minute. And then that's a screening tool to try and assess risk for extended disability and therefore then provide appropriate step care management if needed in collaborative care. The screening tool is a brief 6-item questionnaire known as the Functional Recovery Questionnaire. It was developed, as I said, by a team of us at the UW. I know you can't read this, but that's just a snapshot of it. It's a fairly simple 6-item, but it does reasonably well at predicting who's going to be on disability for an extended period of time. So care coordination in COHEs, obviously has been already mentioned. It requires timely care coordination. That's critical. Health services coordinators within the COHEs provide care coordination and track patient progress. The care coordination is fostered through patient tracking systems that have been developed and continue to be refined and improved. And alignment of financial incentives. During the COHE expansion, care coordination became a billable service. So actually care coordinators now get paid in 6-minute increments for doing this work that we all consider important. As I say, it's an early work in progress, but just to end here with some summary and concluding points, I think the history of the COHEs demonstrate that it is possible to develop a large system transformation that improves quality and outcomes on a population basis and reduces costs, actually demonstrating you can make, I think, some real progress in achieving the triple aim. Some of the keys to success were strong ongoing stakeholder support from business and labor. I think it's fair to say, and I think Gary and others would agree, that we really could not have accomplished what we did without the strong support of business and labor. Labor and industries really over time, it was interesting for me as somebody working at the UW, as a researcher, to really observe what I called the organizational learning. I think I went through at least three directors in L&I. I mean, I didn't go through them, but they were there. But what was interesting is that the agency really, I think, over time learned from these pilots, and they became more willing and more invested in pilot work and in garnering the resources to do that work, and that was critical. And I'll just give a call out. I think those of you in the room that know Gary, to Gary, I think it's fair to say that this would not have happened without his sustained leadership, and he really did serve as an important idea champion for this intervention. There's a lot of organizational inertia. Getting organizations to change what they do and be willing to invest resources in new innovations is not an easy task, and it's not something you can do on the cheap, and it's not something you can do overnight. But if you have the right pieces in place, I think that we demonstrated you can do it. I think another thing that was important was we had good evaluation science, and so we had credible results that the legislature believed in. That was important. The COE system, as I mentioned, is now being refined and adapted for new procedures and processes to support step care management and collaborative care. There will be key challenges here. The work is certainly not done. Aligning financial incentives to sustain this will clearly be important. Implementing IT and administrative systems to support that kind of work will be important. I'm just amazed at how few people, and IT is not my area, but how few people I run into who really say genuinely positive things about electronic health records or IT. It seems like there's a lot of work to be done to make that, to fulfill its promise. And then lastly, I think sustaining strong support within the COE system. So as I said, there's 2,500 physicians at least practicing to provide this kind of collaborative care to address the opioid problem will obviously be a continuing challenge. So thank you.